Hi everyone, I'm Young Kim in Geography. Thanks for coming to the Action on Inequality talk. And it's such a bright day and warm day, so I really appreciate that you're being here. And indeed, every semester we host the Words and Poverty Week event focusing on a variety of issues and very important issues in the study of inequality. And this semester, we put together 6 talks on actions on inequalities. So growing inequalities in our society. That was a topic of this semester. Next semester, spring 2019, we plan to host a week-long event on migration and immigration, so sounds interesting. Undergraduate students, if you are interested in certificate for words and poverty, in addition to your own major, please pick up this sheet from the table on your way out so to see whether there is any overlap between your own major and words and poverty certificate. Good? Okay, then. Today's speaker, Dr. Berkeley Franz, is a professor in social medicine here in Ohio University. She is a medical sociologist whose research and teaching interests include health disparities, hospital-community relationship, and health policy. She's currently co-authoring a book on hospital-community relations in urban neighborhoods that will be published by the University of Chicago Press next year?
We'll see.
Okay, and I think that's the topic of her talk today. And in addition to that, her co-authored book, Narrative Medicine and Community-Based Healthcare and Planning, that was published in 2017. And Dr. Franz has also edited a forthcoming volume of first-person narratives on opioid epidemic in Ohio. So without further ado, let's welcome Dr. Franz.
Thank you. Thank you for the wealth and poverty theme. I'm really excited to be a part of this year. It's a great program. So as Young mentioned, I'm a sociologist. I study medicine. I'm actually located in the medical school, even though I have a sociology background. I'm in the middle of kind of a large book project that's looking at 3 urban neighborhoods and kind of questioning what role hospitals play in these neighborhoods. And I'm going to give some kind of preliminary findings from this project today, but I want to talk really more broadly about what role institutions such as hospitals should play in urban neighborhoods, especially neighborhoods that have been disinvested, that have high levels of poverty and economic insecurity. So kind of thinking more abstractly about what role we want major institutions, especially ones that are nonprofit, to play in terms of improving urban neighborhoods. Just really quickly, I want to acknowledge a lot of students have helped me on this project so far, and I just wanted to thank them for their time and help. They've done a lot of work transcribing hundreds of interviews and doing some historical field work and archival work across the 3 cities. Okay, so just to start out with, I want to kind of lay the foundation of what's happening in healthcare right now, because we're in the kind of the midst of a really important change in terms of moving away from what you may think of as the biomedical model of thinking about clinical care as looking at basically genetics and the processes going on within our bodies. We're currently switching that. The focus of medical care is increasingly not so much on individual patients, but on the health of entire populations of people. So it's less about you going to your doctor and getting medical care as it is about thinking about how healthy our entire neighborhoods or entire cities or counties or states or countries, and thinking about health outcomes of entire groups of people as a way of measuring how well we are doing in terms of the medical profession. So the word that is increasingly used is population health, and you can think of it basically as the same thing as public health. It means the same thing, and it basically, here's the most common definition, it refers to the health outcomes of a group of individuals, but the second part is the most important, including the distribution of outcomes within a group of individuals. What we found is that medicine has been really good at developing certain advances in individual health. What it has not done is improve disparities between different groups of people in terms of their overall health outcomes. So in the United States, you may or may not be familiar, but we have some pretty profound health disparities. I'll talk about a couple in particular, but depending on your economic background, your race, and a variety of other social statuses. You may, for example, not live as long, up to 20 years as long, depending on what your background is. So we have huge disparities even within groups, within neighborhoods, within cities, on how well people are. And so we're in the middle of this kind of shift in medicine to having our healthcare institutions not just focus on being really good at providing clinical care to individuals, but really taking responsibility for the health of whole populations and trying to remove some of these widespread disparities that we've had for a long time. We've had some major success in medicine in terms of improving clinical outcomes for individuals, but we've not had a lot of success so far in terms of removing these disparities, and some of them are even growing. So one of the most important questions that I'm asking in this large book project is, why are we seeing this change in medicine right now? Why are we seeing this shift away from the biomedical model towards some focus on bigger groups of people and some factors that are non-medical in nature, like economic insecurity or racial discrimination? Why is medicine taking the shift away from biology and towards social factors? And so today I'll talk about a few of the things that are going on that are kind of pushing hospitals and healthcare systems and even physicians in this direction. So there's new financial requirements for nonprofit hospitals. So as part of their tax requirements, they are 501c3 nonprofit organizations, and they have new requirements to give back to the neighborhoods around them because they don't pay taxes. They're not otherwise invested in the cities and neighborhoods that they're in. There's also reimbursement changes. If you know anything about how medicine has traditionally been financed, doctors have been paid every time they see a patient. So it doesn't really necessarily benefit a doctor to provide good care because they can just have a patient come back and have another visit and they'll get paid the same amount for it. It's what we call fee-for-service medical care. And there's this move more broadly to about what we call value-based purchasing, where hospitals are being reimbursed only if they change health outcomes. So if you have a patient coming back in with the same uncontrolled diabetes, for example, hospitals won't get reimbursed for this. So they have real incentives to kind of think about ways that they can prevent illness and make sure that people's actual outcomes are changing. And there's also interesting local pressures going on in terms of cities revitalizing and wanting major institutions to play some role as an anchor to drive economic development and also just make sure that they're contributing to kind of a stable economy. So there's this emerging model of hospitals as anchor institutions. And traditionally, anchor institutions have referred to what they call the meds and eds. These are usually hospitals and universities. And they call them anchors because they're unlikely to leave the neighborhoods that they're in. They've been there for a long time. They're pretty well rooted. It takes a lot to up and move a hospital or a university. It happens sometimes. One of the hospitals in my case study is actually one that recently moved. There's a hospital in Columbus right now that's considering moving out of the city, out to the suburbs. So it does happen, but for the most part, these institutions stay put. And so they have tremendous potential then to kind of drive economic development. They're huge employers. They could buy a lot of local products from local businesses. So they have a huge potential in neighborhoods, and some people are really trying to harness this right now and encourage these institutions to start to really embrace this kind of role as an anchor and be a part of revitalizing city neighborhoods. So there's some examples across the country of really innovative population health strategies that some hospitals are taking to try to prevent illness before it starts. And I'll talk about a few of these, but many hospitals are even reaching way out of their comfort zone and doing a lot of non-medical work, things like building houses outside of their campus or planting community gardens, doing crime reduction things that we know will prevent illness, but are very non-traditional for hospitals to do. So I mentioned that there's new financial and tax requirements for nonprofit hospitals, and these arose out of the Affordable Care Act. And it was passed in 2010, implemented in 2012. And so to take a little bit of a longer view before I talk about the ACA, so nonprofit hospitals are about 60% of hospitals in the United States are private nonprofit. That means that they're considered charitable organizations, just like churches. They do not pay a lot of taxes, and so they could potentially be a drain on the cities they're in if they're not giving back through property taxes or other types of taxes. They're also eligible for tax-free bonds and are able to accept tax-free contributions. So there's a lot of benefits to being nonprofit for hospitals. And because of this, there's been an attempt to try to make sure that hospitals are giving back an equal amount to what they're taking in terms of tax exemption. So this has gone back to the beginning of the 20th century. Hospitals have always had to do something in return for their nonprofit status. Traditionally, this has been that they provide free care in the emergency departments, people who can't pay. So if you go to the ER, you don't have insurance, hospitals will write off a certain amount of those patients and say, that's okay, we'll provide the care for free, or we'll agree to take a lower reimbursement rate. And that's their attempt to give back through charity care. In the 1960s, that changed because a lot of people became newly insured through Medicaid and Medicare programs, our public insurance programs in the United States, but also the war on poverty was going on at the same time. And there was this emphasis that hospitals should start to move out of this charity care model and start to play some role as a social institution and be giving something back, especially in urban neighborhoods. And so in 1969, there were new requirements for hospitals to start to do more than just provide clinical care at a reduced rate. They were encouraged to do community building activities, is the language that the IRS uses. And so they were asked to really think about how to improve the neighborhood around them. Basically what's happening in this model is the government is agreeing to let hospitals not pay taxes, and the hospital is being asked to fulfill services that the government would traditionally provide, whether it be through providing health care or other types of social services to try to improve community life. So these requirements changed in the 1960s, but a lot of people were still very concerned that it still wasn't enough, that a lot of private hospitals were actually very financially stable businesses and weren't really giving back enough to equal the tax exemption that they were getting. The hospital I'm going to talk mainly about today is the Cleveland Clinic. If you're from Ohio, I'm sure you've heard of it. If you're from the United States, you've probably heard of it. It's such a giant hospital with a national and international footprint. But it's a private nonprofit hospital, meaning that it does not pay taxes. So there was this kind of increasing concern in the 2000s that something needed to be done in terms of encouraging hospitals to do even more than they were already doing. And so Senator Chuck Grassley from Iowa, for some reason, took this cause up, and he really pressed hospitals, the Catholic Hospital Association in particular, to start to change these requirements. And his work ultimately ended up in the Affordable Care Act. So new requirements were in there that required hospitals not necessarily to do more community benefit, which is the tax language used, but at least to document it better. So they have to show with a report every 3 years that they're actually trying to do something to improve community health and community well-being around them in their neighborhoods. So the specific requirements is that hospitals every 3 years have to do a community health needs assessment. It's a typical public health tool, which means basically you look around in your community and you come up with a ranking of what the top 10 or 20 serious health needs are. And then they have to commit to addressing a certain number of these needs in their implementation strategy. There's some pretty flexible requirements. Hospitals do have to document what's going on around them, but they can choose not to address what they find. They only have to address some things. So if hospitals don't feel comfortable or don't know how to address some things, like poverty comes up in almost every CHNA across the country, many hospitals just say, what do I know about poverty? We're healthcare providers. We don't really know what to do that. So they have an option of saying, we chose not to address this because it's not within our expertise, or we don't have the resources, or whatever. But they have to address something, and every 3 years they have to publish this report saying, here's what we found, here's what we're doing about it. And they have to kind of update every 3 years saying what they've seen and what's changed. So this is a part of this kind of larger movement that I mentioned earlier of medicine moving towards this population health framework. And the specific language that's used is what we kind of describe as moving upstream. So is anybody here familiar with the idea of social determinants of health? Some of you? Okay. So the idea is that we have upstream causes of illness and we have downstream causes of illness. And downstream causes of illness would be things like if you, let's say you have asthma and you go to the doctor and you get it treated. That's a very downstream effect where you're treating an illness after it's already developed. But there are upstream causes of asthma, right? So they could be housing quality, they could be poverty, they could be air quality in the neighborhood. And there's this shift from focusing on clinical care to moving upstream and focusing on these larger determinants that are usually social factors. They're pretty challenging, they tend to be pretty enduring social factors, and trying to address them. And there's this theory in medical sociology called fundamental cause, that poverty, and specifically economic inequality, is the fundamental cause of health disparities in the United States. And that unless we go after economic inequality, whether it be income or wealth inequality, we're never going to be able to address the health disparities between groups. Because over time, we go after some of these downstream factors that we know are bad for people's health, like smoking or junk food, taxes on sodas. And what happens is that health gets better for certain groups, usually privileged groups, and then the disparities actually widen over time if you don't go after this upstream factor of socioeconomic status itself. And so there's an attempt in healthcare to really try to move people upstream towards these social factors, but it's really challenging for reasons that I'll show you in a second. So here's just a little graph from the Kaiser Family Foundation that shows you the relative impact of different factors on health outcomes. So don't tell any of my colleagues in the medical school, but healthcare is only about 10% of what contributes to health outcomes in the United States, is what they estimate. So it's actually a pretty small piece of the pie in terms of what we know has an impact on outcomes. So genetics, factors that we yet don't have a lot of ability to control, is about 30% or a third. Individual behavior is the largest. These would be things like smoking, exercise, any kind of behavioral factors. And social and environmental factors, about 20%. Some sociologists, myself included, would argue that individual behaviors are really a result of social factors because we're always kind of contextualized in certain environments, and the behaviors we take are really constrained by where we live, how much money we have, things like that. But the point is that healthcare really fills a very small amount of this pie, and so it's forcing a lot of healthcare systems to think differently about how they're spending their money. If you know anything about the US healthcare system, you know that we spend a ton of money on healthcare, more than most other countries, and we don't have great health outcomes. And that's largely because we have large health disparities in the United States. Some of our population has very good health, but a lot of our population does not, and it drags the entire health outcomes down when you have such large disparities. And so we're looking for better models on how to invest money and have it be useful in terms of predicting good health outcomes. So today I'm going to talk a little bit about this case study in which I've studied 3 hospitals along with 2 co-authors in 3 American cities to see what they're doing in terms of moving upstream. How are they addressing health disparities in the neighborhoods around them? What responsibility do they feel for health outcomes in the urban neighborhoods that they inhabit? And how does it actually look on the ground in terms of trying to develop strategies to prevent illness and change their traditional mission as healthcare institutions? So the book is called Medical Urbanism, Hospitals, Cities, City Neighborhoods, and Community Health. It will be published by the University of Chicago Press, maybe next year, maybe the year after. We'll see. So as I mentioned, I'm co-authoring it with 2 individuals, one from the medical school here and one from UMass Amherst. Our 3 research sites are the University of Colorado Hospital, which recently moved from Denver to Aurora, Colorado. So it left an urban neighborhood and went to an actually different city nearby, into an urban neighborhood there. That's a very interesting story about how you up and move a hospital. The second hospital is Cleveland Clinic, obviously in Cleveland, and the third hospital is Hartford Hospital in Connecticut. Is anybody familiar with any of these hospitals? Which one? Cool. Yeah, so it seems like in Ohio, the Cleveland Clinic fills a pretty significant role in the healthcare system. But the same could be said for these other hospitals in the states that they're in. In Denver and Aurora, the hospital there kind of ran out of space, which a lot of hospitals do. They kind of need to expand, and eventually they run out of space, and their neighbors got very upset at them. So eventually they picked up and moved to a place where they had more space, so they were able to kind of skirt some of the negative reactions that they had in the city that they were in. Cleveland Clinic, I'll tell the story of today, has had a very different history. Cleveland Clinic's main campus has stayed put the entire time. It's stayed in the same area, but it's expanded rapidly. If you've been to the Cleveland Clinic today, you know that you can get thousands and thousands of steps in just walking inside the building. It's huge. It spans tons of city blocks, and it's really reshaped the urban neighborhood around it. So there are very different kind of stories about each of these hospitals. Hartford is also a very different story in terms of a hospital that's left in a city where the city's kind of collapsing. There's not a lot of people left in the city. Most people commute there. There's not a lot of urban residents. And so what we're doing in this book is really kind of mapping out the hospital's role in the neighborhoods around them and trying to understand what effect hospitals have on health outcomes around them, and how they're starting to reconnect with neighborhood residents around some of these programs to attempt to prevent disease development and improve health. So the foundation of the book is about 210 in-depth interviews that are all completed as of this summer. So we transcribe these interviews, we code them, and then we look for major kind of themes that come out of them. And so I'll talk specifically about a couple of those themes today. So we interviewed all kinds of people around hospitals. Of course, we interviewed people in hospitals, so physicians, nurses, hospital administrators. But we also talked to average people who just lived next door to the hospital or a couple streets away about what it was like to live in a neighborhood with a major hospital there. We interviewed community organizations, people in government, and a variety of other big business owners, anybody who might have some relationship to the hospital and the new programs they were developing. I will include a couple quotes today. They're not real names to protect the identity, especially of the residents. And the general research question is, what role should urban hospitals play in their neighborhoods? So one of the things that really drove our interest in this study to begin with was some data that was available that showed that if you lived closer to an urban hospital, health outcomes were at times worse than if you lived further from an urban hospital. And so it really seemed counterintuitive about why would it be bad for your health to live near a major hospital? And a lot of factors are at play here, including the way that hospitals have remained put in urban neighborhoods that otherwise have greatly deteriorated over time as populations have moved out of urban neighborhoods. But also, there's a real fact that just having a hospital nearby does not mean that your living conditions are good or that you have good access to a hospital. You might live right next to the Cleveland Clinic and not be able to go there as a patient. And so there's kind of developed these kind of contradictions between in the United States, where we put a lot of our resources into acute care hospitals. Why is that not translating to good health outcomes right outside of it? And so we wanted to look a little bit about the history of how hospitals ended up where they are, how health outcomes and disparities ended up how they were around hospitals, and try to understand how and if hospitals might begin to address health disparities right around them. So here's a life expectancy map. If some of you are familiar with Cuyahoga County and Cleveland, you might recognize the neighborhoods here. So does anybody know where the Cleveland Clinic main campus is? Can you tell us? Yeah.
Huge disparity in wealth in the area.
Absolutely. So the main campus is located right here in Fairfax, the neighborhood. Huff neighborhood right above it is a well-known neighborhood that kind of abuts the Cleveland Clinic's main campus. Huff is really well known for having riots in the 1960s. They're predominantly black neighborhoods. And this life expectancy map clearly shows that if you live in the inner city of Cleveland, you live much shorter than if you live further out in Cleveland. So in Fairfax, life expectancy is fewer than 73 years. If you live out one of the outer ring suburbs, life expectancy can be over 83 years. So over 10 years just within the county and life expectancy. And you can see the very, very worst life expectancy is right outside the doors of the Cleveland Clinic. It's one of the most famous hospital systems in the country. It even has an international presence. It's opening a campus in London. It has a campus in the Middle East. They have campuses in Florida. So it has this incredible reach in terms of providing clinical care, and it has an incredible reputation. How many of you would want to go to the Cleveland Clinic if you were very sick? I would. They provide incredible medical care, and especially for people who have very rare conditions. So their main campus is kind of a tertiary facility where people actually fly in for having kind of very severe or unusual illnesses. Oprah had heart surgery there. Saudi princes have come there for cardiac care. They actually fly. A lot of celebrities can rent wings of the Cleveland Clinic to get very complicated and very wonderful medical care. But at the same time, there's this real contradiction in the fact that people living right outside the Cleveland Clinic don't have access to really kind of basic quality of life services, and that they are dying more than 10 years earlier than people who live elsewhere in Cleveland. And so we wanted to kind of get at, what does that mean for a hospital to know that it's providing really great clinical care, but maybe not really driving outcomes in terms of population health. And so I have a couple other graphics here to show some health disparities right around the clinic. So here again, this shows infant mortality, which is one of the largest racial disparities we have in the United States in terms of health outcomes. So right around the Cleveland Clinic, we have some of the worst infant mortality rates. And you'll see here that they are at least twice the rate of elsewhere in Cleveland. And some are even higher than that. So nationally, we have infant mortality rates between black and white babies that are at least 2 to 3 times as high. That means if you are white and you have a baby, your child is at least 2 to 3 times more likely to survive the first year of life, everything else being equal. So it's a huge disparity in average terms. In Cleveland, the disparity in some places is 6 times higher, meaning that if you're black and you have a baby, your child is 6 times more likely to not live the first year of life. It's usually because of low birth weight infants, premature birth in particular. And it's been tied specifically to racial discrimination, so feelings of stress and kind of unequal burden in terms of carrying a baby. We know that stress is not good for us. We have all kinds of hormones that we secrete when we're stressed out. And it turns out that it's not just bad for ourselves when we're stressed out, it's extremely bad for if you're carrying a child. So infant mortality rates have been one of the real ways that we've been able to measure health disparities in the United States, especially between different racial groups. It even transcends socioeconomic status. So here's another graph just showing again what the Cleveland Clinic is kind of facing in terms of population health. And I wanted to show this next graph just to think a little bit about historic factors and trying to understand how the Cleveland Clinic and the neighborhood around it faces such severe health challenges today. And so again, Cleveland Clinic is up here in the Fairfax neighborhood. Does anybody have a guess of what this historic map is looking at?
Redlining?
Yes, so this is a redlining map from the 1930s in Cuyahoga County. And so if you're not familiar with redlining, it refers to patterns of disinvestment and not giving home loans in certain neighborhoods. They were actually graded. The red neighborhoods were given the grade of D, so they were less favorable. These were usually neighborhoods that were poor, that had minorities living in them, and the people either withdrew funding, so there were not a lot of homes being owned in these neighborhoods, or refused to give home loans. So this had effects both on the neighborhood development, but also on the individuals that lived there in terms of not being able to develop wealth and pass it down to their children. So it's one of the main drivers of what we now know is the wealth gap in the United States. So again, you can see that same pattern of infant mortality, life expectancy really kind of overlays nicely on the redlining map. You can see some of these historic factors that have really driven health outcomes today. They go way further back than the current generation or even the last one in terms of understanding how we got to the point where there was such extreme economic inequality, but also racial inequality too. So the question that we wanted to ask is, to what extent are hospitals looking at data like this and thinking we need to change our practices? Should we be doing something different to change health outcomes around us? And some hospitals, not necessarily the ones that I'm studying here, you'll see doing exactly this around the country. They are really thinking broadly about how to expand their medical model to focus on upstream factors. So one example of a hospital I've worked with, Nationwide Children's Hospital in Columbus, they're going into houses and actually fixing houses so that they have good resale value. They're making sure that absentee landlords are addressed, that people have safe spaces to live. They're doing mold, lead abatement to make sure that children specifically aren't exposed to toxic chemicals. Other places in the United States, you'll see people opening free grocery stores, providing prescriptions for healthy foods instead of medicine, saying, here's a prescription for some vegetables, and they're free if you go and pick them up here. Partnering with a lot of different organizations in the community to try to make sure that people have safe and healthy spaces to live, eat, exercise. Others try to remove kind of chronic stress, stressors rather. And there's a lot of really interesting examples of hospitals really taking on work that's not within their traditional skill set. That's not the most common example. So most hospitals are still really shying away from doing this upstream work, but we have a couple innovative examples. So the examples from the case studies that we have, the most upstream ones that I've found so far in terms of interviewing, the Cleveland Clinic and the University of Colorado Hospital have live local programs where they'll have their own employees get benefits to buy houses in the neighborhood right around them. So there's an attempt to try to just improve economic security in the neighborhood, improve housing values by getting people to come back into cities where there are large numbers of vacant properties. They also have hire local programs. So they have pipeline programs where they'll train students, for example, for jobs in the medical profession, but also all kinds of jobs throughout the hospital, whether it's being a janitor, a health promotion, public health worker, all the way to a hospital administrator. They'll train people locally in the community to fill those roles instead of looking outside. So trying to improve employment opportunities in the neighborhood. They also do things that are maybe more within their traditional expertise in healthcare. They'll offer free clinics where you can go and get diabetes screenings or other preventive health screenings, and they'll have community gyms. They'll have safe spaces to exercise, since we know that exercise is an important behavioral factor in terms of preventing chronic illness. So there's a whole range of population health interventions out there, but most hospitals in the United States are really favoring things that are more traditional within clinical care. And many hospitals are very nervous about this population health model because it's new for them, it costs them money, potentially, and it may take a while for them to recoup that money. So there's still a lot of kind of hesitance among hospitals to move upstream and think about taking on some of these programs. And so we're really interested in understanding the kind of internal dynamics within hospitals, but also the external pressures to get hospitals to move in this direction. So I'm going to just briefly present a few of the challenges that I found. I'm going to focus on Cleveland today just because we're in Ohio and because I'm kind of further along with the analysis of the city. But I want to talk a little bit about what challenges they're facing in moving upstream, because they still are very divided within the Cleveland Clinic about whether or not the Cleveland Clinic should be focusing on population health or whether they should be really going after economic insecurity, for example, or racial health disparities around them, whether that's their role or somebody else's role to play. So if you know anything about the history of medicine in the United States, you'll know that medicine and public health have really gone in different directions. There hasn't been a lot of interplay between public health departments and hospitals. They've been very, very separated. And sometimes for competitive reasons, they kind of went in different tracks. And they've had different priorities in terms of fixing illness and preventing illness. They haven't really kind of coordinated a lot in terms of the kind of population health approach. And so one example I found is the Cleveland Clinic in their most recent community health needs assessment. Again, they had to do this with the Affordable Care Act. They identified as one of their priority needs in the neighborhood economic insecurity. It's not surprising. If you've been to either of those neighborhoods, you will know that there is high levels of economic insecurity outside the doors of the Cleveland Clinic. But in their implementation strategy, where they have to publicly commit to doing something about these health needs, Cleveland Clinic stated that they cannot focus or otherwise address the need for community services unrelated to the delivery of health care. So they said, basically, we are not going to move upstream because that's not traditionally what we do. And so they chose not to address that. Instead, they addressed, I think, diabetes and cancer, mainly through the clinical services they already offered. So they really weren't stepping out of their traditional comfort zone and doing some of this community building work. The Cuyahoga County Board of Health, however, their number one finding for a kind of local community need was structural racism. They think that is the most important factor in terms of driving health disparities in their county. And they're doing something about it. They're actually trying to go after these historic effects of current health outcomes. One of their other goals is to link clinical and public health. They know that in Cleveland, there are incredible hospitals there, not just the Cleveland Clinic, but University Hospital System, Metro Health. And they are really going after this idea that we should not be living in an area where we're medically overserved, but we have poor health outcomes. And so they're really trying to get public health and hospitals to coordinate on their efforts. And so you still see this big divide in terms of who's willing to move upstream towards prevention and who's not. And in Cleveland, it's very clear looking at the public health department and their priorities versus the hospital. The other thing is that there still seems to be this kind of concern, even within the Cleveland Clinic, that having them do population health work to prevent, economic insecurity or racial discrimination really is not their job. It's not their responsibility, and they shouldn't be doing it. Because in their eyes, they're doing something equally or maybe even more important in terms of the clinical care they provide. And so here's a really well-known city leader. I've named him Kurt. And he says, their core business is treating the sick of our community and helping people heal or stay well. They're so good at it. And that, I don't think that should be underestimated, because that's not easy, right? That's in fact heroic. So he calls clinical care heroic. It's something that's so important, and we should not be kind of pushing the Cleveland Clinic into doing other things, because this is truly what they're good at. A physician at the Cleveland Clinic, I won't read the whole quote, but he says basically the same thing. He says, the Cleveland Clinic often gets confused as a community resource when it was never its intent and it's not constructed to be that way. He says people will show up at your door whether you like it or not, but that's not what we're here for. We're not here to see people from the community. We're here to give elite care to people that can get here who are very, very sick. He says we have people that do very, very complex things. We don't want to be a community hospital that's here for the people around us. We want to be, have a bigger footprint and being kind of an elite specialty care hospital. And he told us a story that was really interesting about the Cleveland Clinic's main campus. He said, at one point, their emergency department was on the second floor of the hospital, and it was relatively hard to find. So if you were coming in from the neighborhood and you had an acute illness or injury, a lot of people said they couldn't get to the emergency room. Like, they literally couldn't find it. And sometimes they were even redirected towards other emergency rooms nearby, because this was a hospital that didn't necessarily want to be this community anchor. They didn't want to have an emergency room that was there for everybody to use. They really wanted to be doing that elite care, the surgeries and other kind of more rare clinical care. And so he didn't shy away from the fact that they tried to hide their emergency department at times, because that really wasn't their mission or their role. And the Cleveland Clinic does have community hospitals around Cleveland, just not their main campus. So he really sees the main campus role as being very different than other community hospitals. So it was really interesting. And he said, look, I know this is not going to be popular, or the optics of this are not going to be very good, but this is really how I see the Cleveland Clinic. And I think we're kind of distracting ourselves if we think about population health, because we really can't do everything, right? We can't be focusing on clinical care and population health at the same time and do both well. And so that was the kind of concern within the Cleveland Clinic. And there's a lot of disagreement. Their government relations and community health administrators really believe in population health. They want to do it, but there's a lot of pushback still within the organization about whether or not that's what they should be doing. So here's some perspectives from the residents who live outside the Cleveland Clinic. So here's somebody who works at a community foundation, and he talks a lot about this model, like I mentioned, the upstream, downstream model. He says, should you put a fence at the top of the hill so people stop falling down the hill and hurting themselves, or should you put an ambulance at the bottom of the hill so you can rescue people when they fall and hurt themselves? And that's the kind of difference in models in terms of the hospitals at the bottom of the hill and population health at the top of the hill. And he really thinks that medicine needs to move upstream, and that what's been pushing people downhill in Cleveland in particular is racism. He knows that that's one of the biggest upstream factors that's contributing to poor health outcomes, and we need the hospital to really go after that and go after that history and try to start to undo or address the fact that there have been these really big upstream factors causing people to be ill. Here's another resident's perspective. He says they're the largest employer in the state of Ohio, the largest in Cleveland. They clearly have an obligation to improve health around them. They should not just be improving health for people who are in the hospital or who can pay for it. So he thinks they have a real economic responsibility to promote higher incomes and ultimately to promote better health because of it. So one of the most kind of telling findings that we had from Cleveland, though, is that the Cleveland Clinic is really trying to address population health. Some people, especially in their community health wing and government relations, are starting to build these strategies, like I mentioned, the Hire Local program, the Live Local program. They're investing in community clinics. They want to do this type of work, but they're coming up against some real kind of challenges in the neighborhood. And so this is pretty well known in Cleveland. It might not be if you're not from Cleveland, but the neighborhood around Cleveland has a lot of distrust for the Cleveland Clinic. And that's because of the way the Cleveland Clinic has expanded over the last 50 years especially. So you hear all kinds of horror stories if you talk to residents about things that they've heard that the Cleveland Clinic has done. So for example, in the 1970s, the Cleveland Clinic proposed to knock down a bunch of houses in the neighborhood to build a golf course for the physicians. A lot of residents thought that was ridiculous because, like I said, many of these people were still having difficulty meeting basic needs, and they didn't want their neighborhood destroyed by a golf course so a bunch of men could play golf on it. There's a lot of kind of distrust about the kind of priorities of the clinic and sometimes being at odds with the priorities of the residents who live there. And so I hear that come up a lot. There was actually a local councilwoman in the 1970s who lived there who referred to the Cleveland Clinic as the devil. So she actually, that was kind of her rallying cry for getting elected, was to kind of unite residents against the Cleveland Clinic. Because of them being a bad neighbor. They had made especially expansion decisions that really did not take residents into consideration. So they were kind of developed this animosity between people who lived in the neighborhood and the Cleveland Clinic itself. There was not good communication. But population health work requires good communication. When you're trying to prevent illness and actually improve social services, you have to work with local residents. You have to do community-based planning. And now the Cleveland Clinic is really struggling because this history is really causing a potential problem. So here's let's see here, a couple quotes from residents. I don't have to read them, but you can see kind of how very deeply rooted some of this distrust is. And so here's an example from one of the hospital administrators talking about how much this history has kind of blocked their good intentions. So she works in community health and government relations, and she tells a story of how they're trying to do good things, but the neighborhood never really appreciates it or never really kind of sees their good intention of it. So in this situation, the UAE, a family from the UAE donated a soccer field to the neighborhood. And a lot of the residents said, we don't need a soccer field. We need to get rid of some vacant houses. We need to improve crime in the neighborhood. And they were not happy with the Cleveland Clinic just putting a fancy new soccer field from one of their wealthy donors in the neighborhood when there were kind of other and higher priority needs. So again, just another example of this kind of history and kind of difficulty communicating with residents still because of this history. So as I mentioned, one of the biggest kind of conflicts between the Cleveland Clinic and its residents has been about how the Cleveland Clinic has acquired land around it. And so this is the case in a lot of urban hospitals because they are constantly expanding and they need land. So there's lots of different strategies in which you can acquire land. You can buy people's houses when they sell them. You can acquire vacant properties to the city. Some residents in Cleveland assert that the Cleveland Clinic took land from residents in a much kind of more destructive way. And so there's a story that has come up from a lot of residents around the Cleveland Clinic about a man named Winston Willis, who was a black entrepreneur in the 1960s in Cleveland. He originally owned a jazz club in University Circle, right around Case Western, if you know where Little Italy is. He owned a place called the Jazz Temple, where a lot of very famous jazz musicians used to play in the 60s, like Miles Davis. But also Malcolm X, Stokely Carmichael, a lot of very well-known black intellectuals were there giving talks. And it was a place that university students used to hang out. And so you'd have a lot of white and black students from Case Western, for example, going there to listen to music. In the 1960s, it was actually bombed to the ground because people were unhappy about the kind of mixing of races in terms of the jazz club. But he'd ended up going to where the Cleveland Clinic is now, before it was there, before they had expanded, and buying up a lot of businesses. He owned hundreds of businesses, movie theaters, bars, clubs, all kinds of things. He's one of the most famous entrepreneurs in Cleveland. But the Cleveland Clinic started to kind of put some pressure on him, too, because they wanted his land. And there were also a lot of racial dynamics going on at the time. It was the 1960s. It wasn't always that pleasing to people in the city to have a black entrepreneur who owned so much land and had potential power in the city. And so the Cleveland Clinic really started to put some kind of covert and some overt pressure on Winston Willis to give up his properties and to leave the neighborhood. He wasn't willing to do it. There were stories of him being evicted at gunpoint from some of his rentals, the Cleveland Clinic actually taking the property very violently. But the most kind of well-known story that's told in the neighborhood is that he was arrested at some point for writing a bad check. And people in the neighborhood believe that he actually didn't write the check, that somebody in his business wrote the check and that funds were switched to make the check look bad when it wasn't bad. So he was arrested, and he was driven around to different prisons across Ohio. A lot of prisons would not accept him because they didn't think there was evidence of a crime committed. He never signed the check. And so he ended up in Chillicothe, not far from here, and they agreed to take him. And some people in the neighborhood believe that there were some kind of inside connections, and that's why they agreed to imprison him there. So anyway, he was imprisoned, and he was put into solitary confinement right away, where he didn't have access to lawyers. And during his, I forget what it was, 7 to 10 days that he was in prison, his properties were seized by the city of Cleveland. They were gifted to the Cleveland Clinic, and they were demolished by the time he got out of prison a week later. And the Cleveland Clinic's cancer center sits on this site today of where his properties were. So here's a picture of his movie theater. He had this big marquee. And because of the pressures that he had against the Cleveland Clinic, he started to put up some really contentious messages to kind of fight back against what he felt like were restrictions on him. And he was using his free speech rights to kind of protest what he thought was unfair treatment. So here is one of the billboards they changed off, and there's really interesting pictures of him online. But here he says, Cleveland Clinic strikes again, continues its elimination of blacks from its community, food stores and Sears now gone, big blow to blacks. So he would call the Cleveland Clinic out in all different ways on this marquee. We'd have different artistic renderings of it. But it was a way of kind of uniting this community in terms of people who had experienced racial discrimination and were trying to publicly demonstrate what this looked like in person. But the point of going through this whole story is that these kind of stories are still very common in the community. It's not that long ago. It's still part of the kind of community memory. And it's really challenging the ability of the Cleveland Clinic and the neighborhood to work together on some of these upstream population health interventions, because the Cleveland Clinic has yet to apologize or do anything to kind of change what happened. His case actually went all the way to the Supreme Court. He was suing just to get paid for the property that he never got paid for because it was taken from him. And so there's still this incredible rift in terms of the hospital and community working together to improve the health outcomes in the neighborhood. So I will want to leave time for questions, but the kind of overall question of the book and of kind of presenting these findings is just wondering, what should we expect of nonprofit hospitals? Should we expect them to be good providers of clinical care? Do they have some responsibility to address economic security in the neighborhoods around them? Should they be nonprofit at all? I mean, these are kind of bigger abstract questions, but that's really what we're going after in this book, to try to understand what role hospitals might play in community development. And you know, how they would move past some of the really problematic histories they had in terms of interacting with residents around them. So I think we'll open up for your thoughts or questions or any feedback you would have. I would really appreciate it. Yes?
When you talk about the upstream determinants of health, so in the case of Cleveland here, it's about the research method. The people there, so a lot of people are moving in, new people are moving in, the existing residents are moving out. So then it's kind of tough to determine what they did 20 years ago or 10 years ago. So let's say even East Cleveland area or inner city Cleveland, there are Tremont area. So if you talk to people there, then many of them moved in within the past 10, 20 years. And all the residents moved out to Parma area and Parma, and then
Right.
now re-suburbanization. That's what's happening to many American cities,
That's
big
true.
cities. So that's why I was wondering, I mean, when you talk to those people or even using this health data,
Yeah,
it's hard to determine that.
it's hard to tell a cause, right, of what's,
Because
Yeah.
people are changing.
right, because the demographics are changing, the neighbor dynamics are changing so much, people moving in and out. Yeah, that's interesting. In the Huff neighborhood, just north of the Cleveland Clinic, that neighborhood has experienced a ton of change in the last 20 to 30 years. So I think that's a really important question in terms of how you kind of tease that out in terms of what determinants matter in terms of predicting health outcomes. But in the Fairfax neighborhood, where the Cleveland Clinic is actually situated, that neighborhood has been less transient. Mostly because many people are kind of anchored there because their houses are underwater, they can't get out of them, or because people have traditionally just lived there for a long time and they have connections there. So that one, I think there's the health outcomes, and they are actually much worse than the Huff neighborhood. I think it's probably easier to see the determinants that are causing them. But Huff, I agree. I think that's a real kind of limitation in looking at the data in terms of understanding what's driving it. And I think the only way to get at that is probably just through the interviews themselves, through what people think in terms has caused their health outcomes. That's a good point.
So I just have a kind of a question about how you define the community, right? I mean, especially for a place like the Cleveland Clinic that has this international footprint
Exactly.
and is treating patients internationally. I mean, couldn't you possibly make an argument that its community is international in some sense, given the level of service that's provided there? So
Yeah.
where does that responsibility? I mean, where would you stop the responsibility being limited to in terms of its impact? And I mean, even if you were to take a more reasonable approach and say, well, okay, so it's in Cleveland. I mean, so
Right.
is it really just this one neighborhood that we've defined somehow? I mean, how are we defining the boundaries of the community?
Yeah.
And even within Cleveland, right? Is it literally just that one community where the geographic footprint is, or would it be
Right.
Larger. Cleveland in a more broader sense?
Yeah, that's a really important question, and it's one you can answer in a couple different ways. So the first one is that if you're looking just at the tax requirements that the IRS has for hospitals, they actually don't require that they define the community in any way. They can come up with any definition they want. What most hospitals use is their service area, where maybe 3/4 of their patients come from. They'll consider that to be their community. But it doesn't have to be that. It could be an international community. It could be a national community. It could be a specific focus group. You could look at, for example, low-income mothers, and that could be the community that you wish to address health outcomes in. And when we asked that question of administrators at the Cleveland Clinic, they said two different things. They said, we see our community as being the Fairfax neighborhood, the very kind of physical neighborhood we're located in, much more so than Huff, which is maybe only a couple blocks away, but they see themselves as being Fairfax. And the second thing they said is they do see themselves as having an international community. So they see themselves as having this ties to wherever their patients come from, which is a very large geographic area. So I think that's an important question. The second way I would answer, though, that is to think about where they are taking resources from in terms of their nonprofit tax exemption. And that really is the city and the county, right, in terms of what they're not paying back in terms of tax exemption. So some people read this as they have a very specific responsibility to that geographic area because they're not otherwise paying taxes, and they need to somehow make up for that through offering some other services or doing community health building activities. In terms of, and this is more clear in actually one of my other case studies in Hartford, Connecticut, where they have a very kind of shrinking tax base in the city, in the East Coast, where not many people live in the city anymore. Most people commute from nearby cities and even states. And so you have a hospital that doesn't pay taxes, and it's pretty much the only major institution left in a city. That really doesn't leave much in terms of a tax base for the city if the residents don't live there either. And so it really kind of sets up a challenge and a lot of pressure for the hospital to do something or to pay taxes. Some people would argue that they should just not be nonprofit hospitals. But that's a great question in terms of how to think about defining community. And I think hospitals, in terms of a legal standpoint, really have a lot of flexibility to decide which community they want to benefit as part of their requirements.
I just have a comment, and I feel like really biased on how I feel about the Cleveland Clinic and what they should be giving back to the community. But I will say that one, even though they're not paying taxes, the RTA system recently rapidly expanded the public transportation that they offered on the route that directly goes through the Cleveland Clinic. So that is something that I think benefit specifically the low-income community.
Yeah.
But I still feel like they should be paying taxes.
Yeah.
or giving back in some
or
way.
something. Yeah,
Yeah.
transportation is a great example, and that's another way that hospitals really can kind of improve the local infrastructure. Yeah. They did contribute to it, but it actually, there's been a lot of pushback from residents because what they've done is, if I can't remember what road, is that Euclid? Yeah, so you can't cross Euclid except for like every like however many blocks, and so a lot of residents feel like they have to drive way out of the way to get across the street, or it's like more dangerous to drive across the street because cars aren't stopping, and so there's been some kind of pushback. And some kind of cynical people have argued that in Cleveland there's always been an attempt to move traffic through East Cleveland from the suburbs to downtown, especially through neighborhoods that have been disinvested. There's been this argument that they wanted to get people to move through there as fast as possible so they didn't have to stop and look around at what poverty looks like. And so a lot of people have argued that that hasn't really attempted to benefit people living there, but more attempted to benefit people who are commuting in either to the Cleveland Clinic or to downtown. So I think it's complicated, but that's a good point. I think that's a role that hospitals really could play is improving transportation, especially not just to healthcare appointments, but to all kinds of things like grocery stores. Cleveland Clinic, there's no grocery store nearby in the entire neighborhood. So if you wanted to, for example, go and pick up some food or go to Home Depot or anything like that, it's really hard to get there, especially if you need to carry things back. So that's a good point. Mm-hmm.
How do you think, I don't know if this was within like the scope of your research, but the demographics of the people who worked in the clinic, like how do you think that affected the relations, not just as broadly, but in the more high-paying positions? Because I know you mentioned that there's like the pipeline from in the city to working in the hospital.
Yeah.
But there's still like a very large difference between being a janitor and then being either a nurse or a surgeon or internal medicine. So, like, is that line? Is there like a cutoff point where the locals you can only get so far in the pay scale from within the clinic?
Right.
And do you think that kind of bridging that gap would help improve relationships between the people and the?
Yeah, I'll answer your second part of the question first. I think it definitely would go a long way to improving relationships. I think you're starting to see the Cleveland Clinic organization have a lot of diversity through some of these pipeline programs, but like you're saying, not necessarily at the upper ranks of the organization. One example is that they did hire somebody from the Community Development Corporation in the neighborhood who was a long-term community resident. But there's been some kind of criticism of the relationship between the Cleveland Clinic and this development corporation, which controls what happens to land around the Cleveland Clinic. And so they actually took the director of the development corporation and hired her as their community health director. And so you'll see some kind of movements, and she is a relatively high-level administrator. But when you get to the highest ranks, they're all male cardiac surgeons, if you look at their backgrounds, and they're usually white. But I don't think that's quite happened yet. So that's a really good example in terms of how to think about hiring. One of the other things that residents mentioned to us that was interesting in terms of hospital histories is that they still remember a time when the Cleveland Clinic didn't have black doctors. And so there actually was a hospital north of the Cleveland Clinic that was considered the black hospital where black doctors were able to be employed and black patients went. And so there was still this history of black patients and black physicians not feeling welcome at the Cleveland Clinic. So that still kind of, I think, colors a lot of the reactions around the Cleveland Clinic, where a lot of people will say, I don't go there because I don't have good access in terms of insurance. Other people say I don't go there because I don't trust them to go there. I don't feel very safe there. Other residents have mentioned the whole kind of larger medical ethics history in the United States around Tuskegee. And having a hospital that has incredible medical experimentation and incredible clinical trials isn't necessarily a positive thing if you're from a group that has historically been the recipient of medical research outside of informed consent. So there's other kind of questions that need to be addressed in terms of not just the history of the exact hospital, but also the history more broadly of medicine in the United States, and thinking about if you want to do population health work and go after that, you're going to have to address that with residents and can really talk about some really difficult topics. In the Cleveland Clinic, I think that's a real opportunity for them in a majority black neighborhood to talk about what elite hospitals mean in that community in terms of their history, but also the larger medical history. Mm-hmm.
I'm curious about how transferable you believe this methodology that you and your co-authors have set up to other anchor institutions. So when we think of Ohio University, for instance, right, as an educational anchor inside of what has been ranked 9 out of 10 previous years by the Appalachian Regional Commission as a distressed, the lowest economic ranking Appalachian County in Ohio, with one of the largest universities in it. How do you think this method works and
Yeah.
begin with some of those implications or questions?
That's a good question. When we chose these case studies, these 3 sites, we tried to look for cities that weren't too extreme or particular. We didn't want to look at LA, for example, and we didn't want to look at New York and these large cities that maybe were too particular and wouldn't transfer very well. That being said, this is qualitative research, and it's never really generalizable in the sense that you would think of as, survey research or something like that. I think it's transferable in some ways in terms of understanding how histories matter. When I think of Ohio University and its relationship to the community, I think that the history probably does matter in terms of what's being passed down in the community about what the university, who it's here for, people who come in from the outside, whether it's here for people who've lived here. At the same time, there's some real particularities with hospitals right now around the Affordable Care Act and their community benefit requirements. Universities don't have that. So they don't have the same kind of outside pressures in terms of kind of research changing or tax requirements changing that are pushing them into this type of work. And so they may have outside pressures, unhappy people, unhappy communities that will push them into being anchors in a way that's maybe more than they have in the past. But they don't have some of those formal requirements, so I guess it's not entirely the same. But I do think some of the factors about interacting with residents in different ways is probably similar. But that's not my expertise. So it's a good question.
Thanks a lot.
Thank you all.